Hello, my name's Grace Clifford, and I'm the Director for Disability Services at the David Geffen School of Medicine at UCLA. This is a recording of a presentation I did for the 2022 Health Science Symposium, Inclusion in Nursing, Occupational Therapy, and Physical Therapy, looking at challenges and solutions. So to get started, I'd like to just go over kind of what I'll be talking about during this presentation. I'll jump right in with talking about the common barriers we experience while facilitating or attempting to facilitate disability access in the health sciences. So we'll look at the stigmas, the myths, and the false assumptions that can, prove to be burdensome and kind of get in the way of productive conversations. We'll talk through some solutions or recommendations, and then I'll provide my contact information at the end. So if you have questions, you can feel free to reach out or set up a meeting with me to talk through this, as we didn't have the luxury of meeting in person and being able to go over that. So to start, for stigmas, myths, and false assumptions, causes and consequences, I'm going to look at it through these three kind of lenses. So the different lenses that can cause barriers, how bandwidth can cause barriers, both for disability resource providers and faculty, and a lack of flexibility within our systems. So when talking about different lenses, what do I mean by that? And what it means is, many institutions and programs have deeply rooted cultures within particular health science programs, within particular institutions, and we need to be aware of those cultures and how that can impact the dynamics as we're trying to make connections and build rapport with faculty in these areas, and understand where they're coming from. We also have a wide variety of professional, educational, personal, ethnic, and cultural backgrounds within faculties and administrators. So this can impact our ability to connect on disability access as well, because disability awareness and accommodation implementation certainly isn't universal. It looks very different, from institution to institution, but it also looks really different, from continent to continent and kind of cultural and ethnic backgrounds. So being sensitive to that and aware of that and kind of meeting your faculty and administrators where they're at in terms of understanding can be really helpful. Sometimes it's better to back up a little bit and not make assumptions about what is already known or expected. The other piece can just be lack of experience with accommodations. As I talked about, disability awareness and accommodation implementation isn't universal, amongst, institutions. That can mean certain faculty really have never come into contact, with accommodations before. This is especially true with our clinical faculty. We're seeing a growing number of students feeling comfortable in, requesting accommodations and asking for this type of support. But that still means, it's a subpopulation of our greater medical student population that is asking for accommodations in these spaces. So some awareness with faculty can be really helpful, just to kind of acclimate them to, what might be, occurring in the future, or even just letting them know you're there as a resource. Next, we have alignment with different theoretical models of disability, which I'll talk about a little bit more in our next slide. So in terms of the theoretical models of disability, different individuals and different organizations are coming from different perspectives. Previously, we saw much more of a moral model, seeing disability as like an act of God, that people are morally responsible for their own disability, and it's something to build character, and it's part of their process in developing. More commonly, what we see today, especially in the health sciences, is the medical model, which sees disability as a disease to be cured, looking at it as the disability resides in the individual and it's a deviation from normal. This is where the idea of accommodations really comes in, this individualized, case-by-case approach to disability, or looking at it as, how do we connect them to better providers, resources, so this doesn't become an issue for the student. Then we have the social model of disability, which sees disability as a social construction, which is really what we're trying to move towards within the disability resource provider kind of realm, and in general, from a social justice perspective. And this sees disability as a socially created problem, meaning any meaningful solution to this must involve societal change rather than individual adjustment. So this is really the idea of universal design, that if we design systems and cultures and organizations where, individuals with a lot of different characteristics, can navigate, without individual accommodations, because we've inherently made it accessible. That's the win. That's what we're moving towards. One of the next barriers, is something I think if you're a disability resource provider, it's certainly going to resonate with you. And that's the idea of bandwidth, or for many of us, that very shrinking bandwidth feeling, one that can just be staffing in general. There are offices, where the structure of the staffing, you might be a one-person office, or it could even be that you're one person that wears many hats. So maybe, you do academic support, you do disability services. I've seen it where, there's an element of financial aid counseling that's built into these positions, with this idea that there's not enough students with disabilities to warrant having a disability specific position. So that can be a challenge when, you're juggling so many items. Similarly, your caseloads can be a significant barrier, especially if you're working with health science students, because so much of what we do is so highly nuanced. It takes a lot of interaction with the student, reconnection to the student. This certainly isn't a meet once with them for an intake typically, and then, not talk to them again unless something comes up. Quite often it's checking in periodically, especially between that transition between the preclinical curriculum and the clinical curriculum, kind of assessing what will be needed, help them understand, what they should expect transitioning into the clinical environment, and what might, prove to be a barrier or, an additional difficulty for them because of the nature of their disability. There's also the complexity of cases. I mean, we are living in a pandemic. COVID-19 has increased our caseloads, but it's also complicated a lot of different things. So we're seeing students who, aren't just having disability related barriers, but their disabilities are being emphasized or complicated by other life factors that are occurring, whether that's, home insecurity, financial insecurity, other health issues, health of family members. There's so many layers that can go into a student case. So it's not as simple as, a student with one very specific diagnosis, you give them, testing accommodations and they're good to go. There's a lot of students with chronic health conditions or psychological disabilities that, can change in the complexity and how impactful they are for the individual on an ongoing basis. So, we have to really kind of sift through all the different pieces. We have to connect to other offices in order to kind of filter out the items that are really disability specific and support that students. Another barrier is lack of specialized health science knowledge. So for most institutions, they have a more centralized model. Only about 9% of medical schools, speaking from my personal kind of knowledge, only about 9% of medical schools have a specialized med school specific health science or med school specific disability provider like myself. So that means that you're kind of an individual that is looking at it from all trades perspective, and not mastering a particular area or necessarily understanding the nuances between, dental medicine, OT, PT, and medical school. And that can be a challenge. So if you have to kind of start from scratch each time you have these conversations as part of the interactive process and understand the flow, how long the clinical rotation is, where the students are placed for these rotations, it can take much longer because you don't just have that information memorized because you live it and breathe it every day. And then, as I mentioned, the pandemic impacts, can't be ignored, both in terms of, again, caseload, the expectations around disability resource offices getting involved in things like remote accommodations and the complexity of those, as well as just kind of the high burnout we're seeing in our field and individuals leaving to go to the private sector or into the business sector. Similarly, we have to think about the bandwidth impact to faculty, especially right now in the pandemic. So the pandemic has caused a reduction in staffing because of the hit most institutions have taken as part of the COVID-19 pandemic. We're seeing increased workloads and expectations of faculty. Remote learning or hybrid learning is one example. Faculty having to kind of stretch between this virtual hybrid world and the in-person learning experience. A lot of them are struggling with reduced resources and funding, meaning they might have less graduate assistance because of funding. They might have less, grants that they had access to. And then as the pandemic impact, just like, all of us are human, they also experience those personal and professional stressors and are navigating the site expectations. And with the pandemic, we saw, much more limited number of clinical sites. Sometimes there's more competition for it or for those sites for our students, and there's this fear of upsetting a third party that we're working with, and that if we ask them to do something that's above and beyond, which if we're not taking a universal design to learning, and asking for accommodations, might be perceived as adding steps and complications, and this fear that the site will pull our ability to place students there. And so faculty are trying to figure out how to maintain those relationships with the clinical sites while still meeting the needs of the student. Another barrier is lack of flexibility, within our system, from a faculty perspective. Not all faculty feel that it's a transparent process in terms of how we determine accommodations, how students request or receive accommodations, or for implementing accommodations. So again, if we're thinking about the bandwidth issue for DRPs or disability resource providers, not everyone, has the ability, even if they should, to reach out and really walk individuals through the determination process, the interactive process, as well as the process to actually implement the accommodations. So it can very much feel like an unfunded mandate in some ways to the faculty. And it feels just like here, you must do this, but no explanation of why or what to do if they run into, a roadblock or a barrier. Communication can be stressful for them as well. They don't always know where to go with questions, whether or not they can ask questions, knowing whether it's appropriate to connect directly with the student regarding an accommodation. And that can even be, just making sure that the implementation method they selected, is working or the student feels is appropriate, or just checking in to make sure the student's acclimating. It feels like, it's a big secret that they can't engage in any kind of conversation. Otherwise, they might be violating the student's privacy and, get in trouble from a compliance perspective. They're not always sure either about how accommodations are communicated to the site. And part of this has a lot to do with, do you have an internal process regarding what this would look like, and how is that communicated? So they don't know, are they supposed to tell the site that there's a student with an accommodation? Are they supposed to connect with you and you're supposed to reach out to the site regarding the accommodation? Does the student do it directly with a letter? Not really sure about how to navigate that piece of it. So it's important to clarify. And then obviously it's the culture piece again, the fear of the unknown, this feeling that we've always done it this way. Why would we do it this way? Does this create a fundamental alteration? And it's not always, easy or straightforward for them to navigate this process, because there is a lack of integration of universal design, especially in health science settings and in clinical sites. So if we're thinking about stigmas, myths, and false assumptions, we on the left side of the screen, we see a lot of, I would say, probably very familiar quotes. This idea that students won't get accommodations in the real world. If a student needs a reduced distraction environment, they'll never be able to, and then insert profession here, be an occupational therapist, be a physician, be a nurse. Accommodations are unfair to the rest of the class. The disability will put patients at risk. We've always done it this way, which I know is super hard for us to hear as disability resource providers, or most commonly lately, this fear that it is burdensome to the site to ask for accommodations for the student. So, these are the topics that I tend to talk about with faculty, because I know this is something that's on their mind. This idea that the student won't be able to fulfill all the requirements of the program, and explaining to them that the technical standards still apply. The student is held to the same expectations. Accommodations are to give a student the same opportunity to succeed or fail as a student without a disability. There's a fear that students' accommodations will be costly. Most faculty aren't aware that the majority of accommodations cost very little to no money. And especially, when it comes to clinical site accommodations, the majority of the time, an office like mine, a disability resource office, would navigate the funding and cost piece of that. Most faculty aren't aware that students will or are at least are able to receive accommodations on their board and high stakes exams. So I hear, this fear of, are we setting the student up for failure? Because what are they going to do when they get to their board exams? As we talked about before, this feeling that you can't discuss needs and accommodations with the student or check in. You can't hold students with disabilities to the same standards. And then the DRP's role is purely to determine the accommodation and advocate for the student. And I think this is a really popular or common misconception, that our job is to, kind of advocate and be a champion for the student with a disability, rather than the reality, which is we're the advocate for the equity process. So, we're maintaining the rigor and the integrity of the program, while also making sure that we're providing equal access for students with disabilities. So other common concerns expressed by faculty members, and I did these kind of by subheadings, the ability to meet technical standards. So when we're talking about the use of intermediaries, lift assistants, patient transport assistants, or patient safety, there's always that question of, well, how do technical standards come into this? Where's the fundamental alteration line? And for things like use of intermediaries, that really depends on how the technical standards are written. It really depends on how a lot of things within the program are kind of created. There are certain programs, especially within the health sciences, where the ability to provide, kind of direct hands-on care is integral to the program. But in many cases, being able to talk through certain aspects of a physical exam, saying, for instance, in like a medical school situation, a gynecological exam for someone who might have limited dexterity or fine motor skills. In many situations, they can talk an intermediary through that process and still meet the expectations of the program. With lift assistance, patient transport assistance, this is typically actually a non-issue. It's a perceived issue. The reality in healthcare today is it's a team sport, for lack of a better term. Most things are done through group lifts or team lifts for health and safety reasons. Patient transport is certainly not an integral part of a PT, OT, or nursing program. There might be situations where they will raise the concern about limited resources or individuals to take that on, and students typically do that because of their role and their lack of seniority, but they're not an employee in this situation. So having someone else assist with patient transport is totally reasonable. And patient safety, the reality is, again, if the student is able to meet the technical standards, patient safety typically is not a concern. And there's, again, a group mentality to the work that we're doing. There's fail safes in place. From a productivity perspective, when we advocate for breaks, time off from medical appointments, additional time with patients, because it might take them longer to conduct a physical exam or something like that, additional time for patient prep or completing their patient notes, seeing fewer patients, but over more days, or again, intermediaries. There's this fear of, the fast-paced nature of OT, PT, and in nursing, and how are they going to meet productivity if they need to take breaks every so often or have this time off for medical appointments, et cetera. And again, the reality is it's a spectrum depending on the site you're at, the work that you're doing, or the subspecialty you're in. A lot of individuals have different schedules, different pacing, different numbers of days. And we always have to remember the students are not employees. At the end of the day, we're giving them the educational experience, we're helping them develop the skill sets, but we're not saying where they're going to end up. And so in these situations, hopefully the student would have a conversation with a trusted advisor at the disability office to say, if I am concerned about fast-paced nature, high productivity expectations, is there a subspecialty that might be better for me? But the reality of breaks is typically we're looking at, 1 to 2 breaks, over an 8-hour day for 5-10 minutes, the equivalent of using the restroom, which people do throughout the day. Time off for medical appointments for this, I always say whenever possible, they're going to schedule it around, their schedule, but sometimes there's specialists they have to meet with, so that's just not possible. And again, they can make up that time. In terms of the additional time with patients or the prep and the notes, again, these are things that just happen in the course of the actual work, once they're actually in the field. We always find it's a spectrum between kind of the most efficient and quickest, interaction with patients, or completing the notes, to kind of the, taking on the longer side of things. The additional time with patients, one thing I always say as a patient, I don't think will ever fault a provider for spending too much time with them, or taking care and really, hearing them out. So that typically isn't a concern. And again, intermediaries, what we find is it really does not delay the process as much as one would think. From a HIPAA compliance perspective, we get questions about the ability to record and this concern about, the patient confidentiality. And what we equate it to is, it's the same thing as writing something down on a piece of paper or typing it up. You have to kind of guard that and keep that in the same confidential way that you would any of those other documents. So there's ways to, have recorders with kind of codes that you have to program in before you would have access to the recording. And we'd have the same expectations for the student around the ability to record as we would with that written note, that, if they did, lose it or someone else gained access to it, they would be, address their professionalism, concern, whatever HIPAA compliance violation that would look like. Live or remote transcription. There's a lot of question about, having individuals in the space. You typically can work this out with the compliance office for whatever the site is to see what that looks like, because sometimes this is needed for patients. So, it already exists. In those situations, if you're bringing in your own remote transcription or live transcription, or if somebody's there, they just have to go through the same process your student does. So if there's any particular vaccinations they need because they're going to be on ground, any compliance trainings they have to complete, like usually there's a HIPAA training they have to complete and sign off on, you just go through that with the compliance office with the hospital and make sure the individual has all the right kind of documents in order and the right clearances. Same thing for intermediary or ASL interpreters. They would go through the same process as the students, so they would meet the HIPAA compliance expectations. And then the assistive tech and adaptive equipment also needs to go through a conversation, or needs to be conversed about with the compliance office, to look at kind of the specifics of each piece of equipment, how it will be utilized. If it does record, does it record to a cloud or is it directly to the device? And how long is that information shared, as well as just making sure it meets the system security requirements for the hospital system. But the reality is most assistive tech and adaptive equipment will be able to meet those standards. You just have to have that conversation with the compliance office at the hospital or a clinical site. Last but certainly not least is this idea of the burden to the clinical site, whether that's the ability to record and the additional time that might take, the live or remote transcription, intermediaries, and the associated costs of accommodations. But as we touched on before, the cost of accommodations should fall to the institution, because as part of the student's educational pursuits, they're not an employee, they're a student. Intermediaries, ASL, interpretation, all of whether it's the cost or that, making sure that people have the correct training, that really should be on the institution as well. So as a disability resource provider, I navigate those pieces, and with the ability to record, I talk to the student about, which device, making sure it has the security things. Usually, we would be the ones that actually order that and maintain that, and then work out with the clinical site where that would be kept in a secure location for the amount of time that the student is at that clinical site. So a lot of these, as we can see and hopefully hear now, it's misconceptions or lack of knowledge about the reality of the implementation of these accommodations, and the fact that we're not setting the world on fire by implementing these. Like, this is not new and novel. These are very common accommodations nowadays. So if you put something like this out on like the coalition listserv, you're certainly going to hear back from individuals that have implemented these accommodations before. They can offer guidance to it. And I have always found that when you go into conversations with faculty, if you can speak to, the fact that this has been implemented before, at, this program in nursing, or this, program, that maybe is a competitor in the OT field, it starts to reduce some of the angst and apprehension around this process. All right, next, let's talk solutions, the much more upbeat part of this presentation, and thinking about it from building an intentional culture with your health science programs, specifically OT, PT, and nursing. So from a programmatic perspective, I think it's really important to build awareness and harness those teachable moments. So making time for faculty inquiries. I have a time in my calendar, specifically for faculty to outreach. And I try to make myself very available to them, knowing that their time might be limited, especially if we're talking clerkship individuals. I'm thinking about like my surgery rotations and the clerkship directors for that. They might have a very limited window. So I try to make myself available when they're free, to again, build that rapport and to demonstrate that I'm a resource for them as much as I am for students. The importance of acknowledging concerns and discomforts. So a couple slides back, I talked about common faculty concerns. I, had some common quotes on there. Feel free to use that information when you present to your faculty to say, hey, you're probably thinking X, Y, and Z, because it kind of removes some of the tension in the air to know that you're aware of what they might be concerned about. And then, come prepared to those discussions and those consults with, I know you're concerned about this, but here's how it's been handled elsewhere. Here's why, this shouldn't be a concern, but, kind of open that line of communication. I think it's important to keep emails short and informative. Again, health science faculty, I would say, especially in OT, PT, and nursing, have sometimes very limited time. So if they have to really, read through an email a couple times to really gather what you're trying to drive home, some of it might be lost, or it might seem like you're trying to totally have this, exchange via email. And I think that can be difficult. I think you have to invite time to kind of connect, come together and debrief on what's going on and what the needs are, and to hear their questions and answer their questions in the moment. And, let them hear your voice, let them, start to understand that you really are there as a resource. I think it's also helpful to build intentional and responsive programming. So for instance, if your nursing program has been a challenge for past students with accommodations, or that you've run into a lot of questions about the same, concerns about patient safety and patient transport, or managing the third-party relationship with the clinical site, if you start to see those kind of roll in as separate emails, go ahead and outreach to the chair and say, hey, I've seen a lot of emails come through. This is a really common question. I'd love to get in front of your faculty and just offer a time to do a quick presentation. And again, kind of quick, informative presentation on X, Y, and Z, whatever the topic is that you tend to see a lot of questions about, and then really open it up for questions. Create that open line of communication and encouragement to reach out to you with questions, that, there isn't this wall that you have to live behind because of the compliance piece of your position. Um, Identifying program liaisons and touch points can be really helpful. Someone, if you are over you know, a disability resource that's office that's over everything, meaning you have undergraduate, graduate, professional programs, and you're managing maybe a small team or a large team, whatever it is. It's important to have a liaison that's living and breathing the program, that maybe can answer some of those questions and develop a really close rapport with them. So then they can tell you who to connect with. They can help be your voice within the program to encourage, other faculty reach out to you. They can help you navigate clinical sites and making those connections to clinical sites. And a strong liaison, when you can't have a specific person assigned to like nursing, PT, and OT, can really go a long way in streamlining the process. When you see or start to notice that there's a particular faculty member that's really going above and beyond, or you're hearing it from students, a faculty member that asks a lot of great questions, that reaches out to you when they get accommodation letters and wants to really know how to best do this, write that down somewhere. Keep a list of those faculty advocates in the areas, and recognize them, whether that's as simple as saying, hey, I talked to this student the other day and they remarked on how available you have made yourself to them and how helpful you have been in implementing the accommodations, and that you go above and beyond. That's a nice, really, no cost, low cost, time wise way to recognize the faculty, but also, make sure to let their supervisor know that if there's opportunities within professional organizations to recognize them, nominate them for things, make it a good thing that, disability advocacy and access is a part of their work and something they're excelling at. Similarly, raising that in terms of potential letters of recommendation or support for faculty tenure. So I've had faculty that I've reached out just to say, hey, the student gave me great feedback. Like I said, hey, I've always really appreciated your questions. I appreciate you're so candid and with me, but you're also really open to feedback. Let me know if there's anything I can ever do to help. And I've had them then reach out and say, hey, I'm applying for tenure. Would you be willing to speak to your work with me in relation to disability access in this area? And I'm like, absolutely. And I love that faculty start to see that as something that should be a positive thing contributing to the strength of their tenure application. Sharing success stories. So I think it's really easy to remember the students that took up entire weeks of your life, that were difficult, that maybe, even if they hadn't had the disability, would have struggled to succeed in the program. I think it's really easy to remember the ones that kind of ended up being kind of frustrations for faculty and potentially the disability resource office, but you have to also highlight the successes. So, recognizing with the department, a student that it took some time maybe to figure out the path forward and to get the right accommodations in place, but, talking about how well that went. And that could be something that really could be something to focus on in their program and to lean into. We had a situation at a previous institution about a provider that after being accepted to the program, had a cervical spine injury, ended up paralyzed from the waist down. And so faculty really went out of their way to figure out, okay, how are we still going to make this work for the student? Getting a grant for a standing wheelchair, coaching them all along the way. So making sure to circle back and say, like, that's something we did, let's talk about this at, potentially a conference. Let's potentially write a paper about this, and talk to the student about their comfort in being part of student panels for professional organizations. Share the success stories and remind them of the successes. And I think last but certainly not least is be excited and confident when identifying access solutions. So I think it's easy for all of us to sometimes read over some documentation, read over the requests from students and going, whew, this is going to be a challenge, and you might be nervous. You might be like, how are we ever going to do this? But I think you have to do your background, research. You have to come prepared, like I said, but also just be excited. Be like, this is still the student, we accepted to the institution as part of our admissions process. They're bright, they're motivated, and this is an exciting opportunity for us to be innovative and to work collaboratively and to support a student in our program in a really meaningful way. All right, solutions institutional. So I think this is about the importance of institutional advocacy. So, I think it's always important to think about key data points you can collect and share. That can help you with things like, staffing barriers, faculty barriers, things like that. So things I tend to collect are, what is my current caseload? Specifically, what is my caseload for health science students separate from the other ones? And how much time do I spend on that? And so that's part of the reason I also have appointment type. So if I have quite a number of appointments specifically for clinical accommodations versus your typical intake, or for board exams, like applying for accommodations on the NCLEX or the PT or OT boards, I track those because those take time. As I said, high stake exam support letters, how many of those you end up writing, because those can take additional time if you're doing something beyond just the form that sometimes is required as part of the process. I track faculty and site consults. So when I'm talking about site, I'm talking clinical sites, because again, that's time that's really essential to track and to spend. So if I have to make sure that we can protect time for that for disability resource providers that are working with health science students, I want to be able to demonstrate how much of my day is already kind of committed to that or has been committed to that. I also look at accommodation types, because certain accommodations, once implemented, take very little kind of ongoing maintenance or support. Others are very time intensive. So some of the attendance accommodations can require a lot of follow-up, consults with faculty, clinical accommodations. It's really important not to just approve them once you determine them and say, okay, I think you're good, reach out to me if you need anything. You need to make sure to check in both with the student and the site to make sure it's going okay. And then it's never bad from an anecdotal perspective to kind of write down complex case examples, and present that qualitative data in addition to the quantitative, showing an example how determining one student's accommodation could have been a solid 2 weeks of work, 40 to 80 hours of your time. I also think it's helpful to share and promote articles on disability related innovations or innovations and collaborations, or again, complex case examples. Highlight what other schools are doing, especially think about who the schools are that when your faculty members hear that the name of that school, they're like, ooh, we want to be doing what they're doing or doing better. So share that, even before it's a need for that particular organization. And then I highlighted raise awareness of faculty barriers. Again, we're an advocate for the equity process. And one of the major, barriers to equity is resources, it's staffing, it's lack of communication, as we talked about. So raise the barriers that exist in the faculty end, advocate for faculty in the same way you do for students, because you're advocating for improving equity when you're raising awareness of those barriers for students and faculty alike. And then faculty also will be appreciative of that and will see you as a resource and connect to you. And then last, but certainly not least, advocate for disability inclusion in your justice, equity, diversity, and inclusion discourse and conversations, or the fancy way of saying it is Jedi. And as a Star Wars fan, I love to say that. So, I think disabilities, diversity is, especially with the pandemic, is becoming more common, but is still quite often left out of diversity, awareness months, or diversity initiatives and programming. So connect to your programs, especially a lot of health science programs have specific diversity offices for their program. So reach out to them and say, how could we include something on disability as part of this? Could we have a student panel? Could we bring in a speaker? Or could I do a presentation on common clinical accommodations during a faculty training, related to diversity? Just start to kind of infiltrate and become part of that conversation, and encourage your justice, equity, diversity, and inclusion offices to think about disability as diversity. So if we were in person, at this point, I would have group individuals come together, talk about 1 to 2, case examples or situations that led them to participating in this particular session. Because you don't have that opportunity, I want to invite you that if you have an experience or a question related to facilitating disability access in an occupational therapy, physical therapy, or a nursing program, feel free to reach out to me. The next slide, I have my contact information. My work cell is 424-402-9864. You're welcome to call or text that. So I purposely have a cell phone for work to encourage individuals to take advantage and connect via text if that's quicker. You're welcome to email me at gclifford, CLIFFORD, @mednet.ucla.edu. Or I have a Calendly link you're welcome to type in or click on and connect to me. I'm always happy to be a resource, because a big part of the work that we're doing is becoming more comfortable in having these conversations, networking, and getting someone that we can talk to about what have you done in this space. So I'm happy to be one of your first in your network if you're new to this field. And then I like to end every presentation with this particular quote from Harvey Cushing, who was the father of neurosurgery. So this was a letter to Henry Christian, also a physician, on November 20th of 1911. Dr. Cushing said, "I would like to see the day when someone would be appointed surgeon who had no hands, for the operative part is the least part of the work." And I think that's really important to think about, like how innovative and groundbreaking that in 1911, Dr. Cushing was where we are today, understanding that the work we do is, so much greater than kind of what it seems on the surface, and that the ability to kind of think through these pieces, to do the work, is the more important part than some of the physical aspects, which can be lost. All right. Again, I really appreciate you taking the time to listen to me today. If you have any questions, please reach out. I'm just going to put my information up one last time for you in case you have any questions. And again, thank you. Take care.